Miriam Dickinson and Bethany Quam. The title of this about 30-minute presentation is called Advanced Methods for Primary Care Research, the STEP wedge design, and they will be going through some examples. And part of this is to give them an opportunity to give more detailed examples. And this particular ancillary material complements so nicely a 90-minute webinar also available through the AHRQ PBRN website entitled Advanced Methods for Primary Care Research, the Stepped Wedge Design. And both of these modules will be located in paired hyperlinks. So I encourage you to go back at your leisure and listen to that webinar, and it's all that we have it synchronized with the video as well. So as I said, we have two presenters today. Dr. Kwan is Assistant Professor in the Department of Family Medicine at the University of Colorado School of Medicine. She is a social health psychologist with research interest in health behavior change in primary care settings. She's particularly keen on having her career facilitate improvement in the quality and effectiveness of behavior change interventions in primary care based on platform of patient-centered outcomes research, healthcare informatics, and behavior theory. And our second presenter is Dr. Miriam Dickinson, who also currently hails from Colorado. She is a professor and biostatistician in the Department of Family Medicine and the Accord Center for Health Outcomes Research at the University of Colorado. She is a senior scientist for the National Research Network of the American Academy of Family Physicians with postdoctoral training in health services research. She brings expertise in study design and the application of complex analytical methodologies to the challenges associated with practice-based research and cluster randomized pragmatic trials. I also have an acknowledgement before I hand it over to the fabulous doctors, is at the North American Primary Care Research Group meeting in late fall of 2014, Dr. Kwan, Dr. Dickinson was joined with Dr. Gillian Bartlett and Mr. Christopher Meany, who gave a wonderful workshop about step wedge design, which is well suited to bring to the PBRN community and others who are interested in such methodologies to pursue and determine their appropriateness. So with that, I will turn it over to our presenters, which will be Dr. Kwan, who will, well, actually, excuse me, Dr. Dickinson, followed by Dr. Khan. Thank you.
Okay, well, I will start and just introduce this session. Today we'll be talking about designs, variations, and examples of step wedge designs. So the primary designs in a cluster randomized step wedge trial are the repeated cross-sectional design, which we call here design A, and a cohort design, which we call here design B. And there's a variation that I'll describe in a moment. But keep those in mind. They're really quite different, although you can have both elements in the same trial. In repeated cross-sectional design, clusters cross over from a control to an intervention condition at the designated time point, but individuals do not cross over. Individuals are designated as either control or intervention depending on when they entered the study. They're generally enrolled during one phase or the other phase. They're followed up for a fairly short time point, maybe just once, maybe just one observation, sometimes a short follow-up period. And the key feature of this design is that you have different individuals in control and intervention conditions. Now, design B, this cohort design, is a little bit different. In the cohort design, clusters cross over and individuals change from the control to the intervention condition at the time that the cluster crosses over. So the key feature here is that you have the same individuals in the control and intervention phases of the study, and their condition changes when the cluster crosses over. This has ramifications, obviously. Usually individuals are recruited at the beginning of the study and followed throughout the entire study instead of having a fairly short follow-up time as in Design A. There's variation on this design where regional level randomization can be used, and crossover order is randomized at, say, a region or an organizational level. Clusters or practices could actually be recruited at the time of the implementation for that reason if you can ascertain outcomes from existing data, such as health records, EHRs, that sort of thing. The more common use of this is the cohort variation, but it would be possible to do this in a repeated cross-sectional fashion as well if you had good records available. So now I'm going to turn this over to Bethany, and she will give you a number of very interesting examples of these designs and how they have been used in practice.
Thank you, Miriam. So as Miriam mentioned, I'm going to talk about one example from the literature representing each of these designs and design variations. The literature in stepped wedge is really expanding very rapidly, and what you often see in the literature is a lot of study protocols, but not a lot of results. So the examples I'm going to be presenting upon are those for which there are both protocols and results available. So for design A, which is that repeated cross-sectional design in which clusters cross over, but individuals do not. I'm going to be referring to work by Dainty and Morrison and colleagues regarding their intervention to implement targeted temperature management in post-cardiac arrest patients. To look at design B, the cohort design, I'll be describing work by Mahertu and colleagues regarding free school breakfast and its impact on children's attendance, achievement, and hunger. And for the design variation, looking at that region level implementation, I'll be talking about Golden and colleagues' study of the Washington State community level randomized trial of expedited partner therapy for chlamydia and gonorrhea. And each of these references are available in this slide deck at the end as well. For each example, I'll describe the intervention, the motivation for use of stepped wedge, the specific design and analytic approach used, and the findings and interpretations that really led from the design that they used. Details on the motivations to use stepped wedge and the design and analytic approaches can be found in the main presentation material that Rebecca Roper mentioned previously. Just to summarize some of the motivations for utilizing stepped wedge, these are interventions that are shown to be effective in more controlled settings and are ready for large-scale dissemination and implementation. Interventions for which there is lack of definitive evidence of effectiveness, but belief the intervention will do more good than harm. Where there is need for cluster-level implementation, or all must receive the intervention, all clusters must ultimately receive the intervention. When there are questions about reach, effectiveness, or impact at the population level, questions about implementation. And it's really ideal when there are outcomes that are process-oriented or short-term. Okay, so go ahead, go to the next slide, please. Okay, so design A, the example for design A I mentioned is Morrison and Dainty and colleagues talking about looking at targeted temperature management after cardiac arrest. So their intervention involved with a passive phase and an active phase. In the passive phase, they identified champions, they gave didactic presentations, and they distributed a standard therapeutic hypothermia protocol. In the active phase, this is when they actually implemented the intervention. They engaged a collaborative network of hospitals. They implemented reminder systems. They actually started using those protocols and encouraging use of those protocols. They provided ad hoc education and audit and feedback. Their motivation for utilizing stepped wedge is that targeted temperature management is an evidence-based practice for patients that are resuscitated from cardiac arrest. It involves cooling to 32 to 34 degrees Celsius for 12 to 24 hours following return of spontaneous circulation. They believed that the intervention would do more good than harm, and so it was unethical to keep it from the control hospitals. However, there was lack of adoption in clinical practice of this known evidence-based practice, and there was a need to study implementation. There were practical limitations to simultaneous rollout in all hospitals, so a step design with sequential implementation made a lot of sense to them, and they were also very interested in modeling the effect of time. Next slide, please. Their design involved 8 to 10 hospitals that were randomized to one of 4 waves. This is not a lot of hospitals, but because stepped wedge design allows you to have greater power, you can make do with fewer clusters. Their wave interval was 4 months, so several of the hospitals switched over to the intervention after each wave that lasted 4 months. And notably, as this is design A, the individuals that entered the hospital at that point during each of those different waves, depending on the phase of this study, whether the hospital had switched over to the intervention or whether they were still control, the individuals were either in intervention or control depending on that time point. And we assume that there is, or at least hope, that there's a low probability of a repeat event, a low probability of repeat cardiac arrest, and therefore people are only in the intervention at one point in time. The primary process outcome was percent of post-cardiac arrest patients receiving appropriate targeted temperature management, and the clinical outcome was survival to hospital discharge. And these are both process and rather short-term outcomes. They used generalized estimating equations for their analysis. And the results, they found that 26% of patients eligible for targeted temperature management received this treatment during the passive phase versus 9% at baseline. And they observed no incremental improvement during the active phase and no effects on survival to discharge. Okay. All right, so the next example was a cohort design that is design B. In this study, they examined the effects of a free school breakfast program. The intervention involved primary schools in New Zealand that would offer a free daily school breakfast program, either based on the Red Cross or the private sector. Both of the Red Cross and the private sector had these programs that they were looking to implement in schools. Their motivation for stepped wedge was because there is existing evidence of positive effects of school breakfast programs on nutrition, health, and attendance for children from disadvantaged communities and developing nations. But they were looking to study the effects on academic achievement and in other populations. So the motivation was they thought that it would do more good than harm, and they really wanted to examine implementation in other settings and populations. Next slide, please. Okay. And in this design, there were 14 schools that were randomized to one of 4 waves, and the wave interval was 1 school term, and there were 4 terms per school year in New Zealand. Children were enrolled at baseline and then crossed over from control to intervention when their school did, and that is the key feature of design B. And the outcomes they examined were school attendance, academic achievement, including reading, writing, and numeracy, and self-reported hunger and eating breakfast every day. They used linear mixed models, which accounted for clustering within the school and repeated measures within the child. Their results, they found that program attendance was very low, and they also observed secular trends in school attendance, which tend to decrease throughout the school year, and also secular trends in achievement, which tend to increase throughout the school year as children learn. However, there was no effect of the intervention. So the stepped wedge design allowed them, and really these linear mixed models allowed them to make a distinction between these more secular trends throughout the school year versus the effects of the intervention. And while they did see that the intervention reduced short-term hunger, children were less hungry when they had eaten more closely to when the assessment was done, there was no effect on eating breakfast daily, such that they determined that children were really replacing breakfast at home with breakfast at school. Next slide, please. All right, so the final example is the design variation in which the randomization occurs at the region level. So the intervention described by Golden and colleagues was a public health program to promote medical providers' use of expedited partner therapy, or EPT, for sexually transmitted infections, or STI. Their motivations for using stepped wedge were, again, you can see the theme here, that EPT is a clinically beneficial intervention, that there's evidence that this is effective, and however it was not well implemented across the state. Not a lot of clinical practices were utilizing this therapy, and they also weren't sure whether there was a real population level impact, whether implementing this intervention across the whole state would have a substantial effect on population level STI infection rates. And the state had made the decision that everyone would eventually adopt the intervention. This was not a question, it was assured. However, the state was willing to randomize the order in which the various parts of the state implemented the intervention. Next slide. So their design, they had 23 local health jurisdictions, which are comparable to counties, they said, in Washington State, that were randomized to one of 4 waves. And in this particular case, allocation was concealed until the time of implementation. The wave interval was 6 to 8 months, which is a fairly long wave interval. And practices within local health jurisdiction were recruited at the start of their local health jurisdiction's wave. And outcomes were measured using existing population surveillance at baseline and in the last 3 months of each wave. The analysis was a mixed effects generalized linear model with a log link, and they were able to model random effects of both the local health jurisdiction and practice within local health jurisdiction. And they found that STI rates decreased overall over the course of the study period. So the stepped wedge design did allow them to look at the sort of longitudinal trends. And they found that while the intervention appeared to result in a 10% reduction in sexually transmitted infection rates, this was not statistically significant. And they concluded that the study was insufficiently powered to detect that size of an effect. And in the stepped wedge design, somewhat larger effect sizes are, as in other study designs, much more easy to detect. And so in preparing to use stepped wedge design, doing a power analysis, considering expected effect sizes, and really varying the number of people, the number of regions, the number of steps that you're using or waves that you're using, to really carefully plan in advance is advised. So those are the 3 examples that we wanted to describe for you today. In the last slide are references that include both general references for the use of stepped wedge design, as well as the references for these examples that we've provided today.
Great, thank you so much. So we just want to thank everyone for taking the time to listen to this recording. On the screen you'll see information for obtaining CME credit, and please just send us an email at pbrn@aptasoc.com for your CME Certificate of Participation. We also invite you to join our listserv and participate in our upcoming events on March 4th and May 1st. And here's the PBRN listserv information. Thank you again. That concludes today's webinar.